Hello, everyone. My name is Jocelyn Castillo, Community Health Specialist at the Yakima Health District. I'm joined today by Melissa Sixberry, Director of Disease Control at the Yakima Health District, as well as Dr. Teresa Everson, Health Officer, also from the Yakima Health District. And today we're going to be sharing some new COVID-19 updates in Yakima County as of November 6, 2020. If you have any questions about this update or any questions that you would like us to address during our next update, please leave them in the comments section of this post. And so to start, I'm just going to give some quick updates on our current case counts. As of yesterday, we have had a total of 13,161 cases of COVID-19. This is an increase of 444 cases from our last update 2 weeks ago. In the last 2 weeks, we've also, the number of hospitalizations due to COVID-19 has doubled. For example, during our last update, we reported 8 individuals who were hospitalized, and now that number has increased to 16 individuals who are now currently hospitalized due to COVID-19. Only one person is currently intubated, and unfortunately, we do have 7 more additional deaths to report, raising our total count to 248 deaths. And while COVID-19 continues to spread in our community and affect members of our community, it's still important that we continue to follow the recommended public health guidelines, such as practicing social distancing, wearing masks in public, limiting gatherings to 5 people or less outside the household, staying home if we're sick, and getting tested if we have COVID-19 symptoms or believe we may have been exposed to the virus. And then just a reminder that all of this data that I just shared is available on our web page. And let me share that with you. And so if you go to yakimapublichealth.org and go to our data summary page, you'll see that the case counts that I just gave over here. Let's see. Can be found right here down below, along with additional data on the number of recovered people, the number of people who have recovered from COVID-19, and then also some key COVID-19 metrics for reopening from the Washington State Department of Health. And so with that, we're going to hear now from Melissa and Dr. Everson. Do any of you have any updates you'd like to share before we move on to the frequently asked questions?
Sure, I'm glad to start with some thoughts. So thank you, Jocelyn, for sharing those numbers. I know we've mentioned all along that we'd be paying pretty close attention to our metrics and not just our cases, which we expected to go up as we expanded our community-based testing, but more importantly, watching our trends in hospitalizations. And really, we watched for a couple of days to make sure that any increase seems like a true or a valid increase. And Jocelyn mentioned that we do seem to have doubled our hospitalizations. That is a trend that we have maintained. So I do think that indicates that we do have true increased spread in our community. It's not just a case of us having more positive test results because we've expanded our testing capacity. So I do think it's important to maintain that vigilance and follow all of those safety measures that Jocelyn reminded us of. With that, I know that we are allowed to do quite a few things now that we have moved to phase 2, which includes being able to gather with up to 5 people outside the household per week. But every choice that we make to do those things, if they're not necessary, does still place the community at risk. So when you're making your plans, I just want you to keep in mind that the more we choose to socialize and the more we choose to be around other people, the greater the risk to not just yourself, but the community as we see that transmission happen. So please keep that in mind. As far as how transmission is happening or where transmission is happening, we do still have cases from time to time in our long-term care facilities. It's not quite as much as we were seeing in the spring when we were peaking with our cases, but we do still see cases consistently in long-term care. We are still seeing cases in our larger employers, specifically our agricultural employers, in the county. So that is something that we're still working really closely with them on and we're concerned about. But at least 90% of the cases that we see in our county are not associated with these kinds of congregate settings. So they're not things that we can blame on outbreaks. 90% or more of the transmission that we're seeing is happening in these socialization visits, these encounters with extended family. So they are things that are happening when we're interacting with each other in ways that may not be necessary, which is hard to say because I, like everyone else, am really craving social interaction with people. I haven't hugged my best friend in 9 months, and that really is hard. But as much as we can avoid these interactions, the better. So please keep doing Zooms and WebExes and Teams and whatever you can to be getting some face-to-face time and doing your best to avoid unnecessary in-face interactions. Anything you want to add to that, Melissa?
No, I think you did great. Thank you.
Well, thank you, Dr. Everson, for that update. And so now we're going to move on to some of the frequently asked questions we received from the community. So the first question is, do the COVID-19 hospitalization numbers include only people from Yakima County?
No, so we get reports every day from all 3 hospitals on how many individuals they have who are confirmed COVID cases, as well as PUI, so person under investigation for COVID. The numbers that we report out daily are any individual, regardless of their county that they live in, that are hospitalized in our county. But those numbers also don't reflect our county residents who have transferred out to other hospitals as well.
All right, thank you. Second question is, what classifies as an underlying health condition?
So there's a lot of categories that can put you at a higher risk for COVID-19 complications, a lot of them being hypertension, diabetes, COPD. There's a huge list that's on the CDC website, but one thing that we did do is we had listed out those individuals who were under the age of 65 who died from COVID-19 to look and kind of see what were the underlying conditions for most of those. So can you see my screen, Jocelyn?
Yes,
Perfect.
we can see.
Okay, so what this came back with was for our individuals under age 65 who died from COVID-19 in our county, most of them with underlying health conditions, which were diabetes, hypertension, and obesity being the top 3, which affects a large portion of the community here in Yakima County. So these aren't conditions such as hepatitis or coronary artery, like severe coronary artery disease or history of stroke. These are things that many people have right now and may have and don't even know they haven't been diagnosed with them yet.
Okay, thank you. And then the next question is, where are rapid tests conducted and how should people interpret them?
Melissa, did you want to take the first piece of that? Where are they conducted?
Yeah, so some of our rapid tests, Yakima Valley Farm Workers Clinic does rapid tests, so you can get results in about 15 minutes. We also have some of our local urgent cares that are doing those, and also Sunnyside Hospital does rapid tests, and Virginia Mason does some rapid tests for inpatient patients.
And then the second piece of that, as far as how should they be interpreted, I would start by making an overarching statement that if you get a positive result, I want you to act like it's a true positive result. I'll have some follow-up as far as how to treat different kinds of positive results, but while you're waiting any kind of a verification, if it's indicated, you really should treat a positive result like it's true and isolate yourself as much as possible. Make sure that you're letting people know who may have spent a lot of time with you or greater than that 15 minutes, less than 6 feet, that they may be contacts. There are 2 different kinds of rapid tests. The one that we have had the longest in our county is a rapid PCR, which stands for polymerase chain reaction, and it is a very good test. So if you have a positive PCR test, which are things like the Abbott ID. I don't know if anybody's following that in the news as far as the names of these tests, but it is a very good test. That is a believable test. There are very few false positives, which means a positive test is truly positive. So if you have a positive PCR, please believe it, isolate yourself, make sure you're talking to contacts. We will be in contact with you. We, meaning public health, will be in contact with you to make sure that you're safe, that you're supported. The second kind of positive test that is becoming increasingly available is an antigen test. The most common maker of the antigen test right now is Binax, but there's a couple of different ones available. The antigen test is a little bit less specific, and I'm using kind of scientific words here. That word specific means that there's a higher risk of false positives. So when you have a positive, we look at that in a couple of different ways. We still want you to act as if you're positive, make sure you're following all of the recommendations, but we will look at some background information. If you have been in recent contact with somebody with COVID, then we expect that that positive test is a valid positive test. If you have not been in contact with anybody that you're aware of that has COVID-19, then what we're going to do is ask you to get a backup test, a PCR test, since that one is a little bit more accurate, to confirm that positive. And ideally, that test will happen at the same time, ideally. But if it doesn't happen at the same time, then certainly within 48 hours, that's the guideline from the state. Anything you want to add to that, Melissa? I know this is getting very complex, but I just want to hammer home. If you have a positive test, you need to act like you're positive, and then you will get information if there's anything else you need to do to confirm that.
Yes, so like Dr. Everson said, treat your positive as a positive and isolate. If you are, the idea of doing a test, if it's negative, the idea of following up with a PCR at that time is, if you're negative, we don't want to have you out assuming that you're negative when in fact it could have been a false negative. So that's why ideally you would take both of them at the same time. I'm trying to think of the best way to explain why you would do both at the same time. One being because if you are positive, we want to identify that right away. But then if it's negative, we always send off for a confirmation.
Yeah, and I guess what I would say is we don't want anybody to be impacted more than they have to. That's why we want to confirm that test that could be inaccurate. So we don't want your lives disrupted any more than absolutely necessary. We'd love to confirm those positives within 48 hours to make sure that they're true. But if you've been in contact, you need to believe that's true. The other piece of this that I don't think we've explicitly mentioned is if you have symptoms that are consistent with COVID, you need to be isolating yourself. Yes, you need to be getting tested. Some people may not have access to testing or may have concerns about it. You really need to be treating yourself like you might have COVID, because there's still a significant amount of COVID circulating in the community, amongst other things like common flu, common cold, but it could be COVID because we do have that in the community. So please take precautions if you're sick and make sure you're getting the help you need and getting tested.
Well, thank you, Dr. Everson. That was very useful information. And then we have another question for you, and that is, why did you decide to tier school reopening?
Yeah. I will start out by saying the school reopening was a joint conversation between superintendents and our health jurisdiction. And we had conversations for a couple of months about the coming fall school year. And in following our cases, watching our cases trend down, we got to a point where we determined that it was likely safe to be considering some limited in-person school. And so we gave a recommendation to start that limited in-person school, and looking at all of the evidence from other parts of the world that had already had in-person school as far as what their successes were, what didn't seem to work very well as far as they were seeing large amounts of transmission, was we have seen that the younger the child, the less they seem to transmit. And I want to make it really clear that children can and do transmit COVID. They just seem to do so less than adults. So part of the reason to start with the youngest learners first was that they have less risk of sharing COVID. That doesn't really speak for staff. Staff are mostly, it should all be adults and can still transmit pretty efficiently. So it seems safer for kids. And the other big piece of that is our youngest learners are the ones that seem to be struggling the most with this, especially kids who don't have any experience with school yet. So those entering kindergarten, they're the ones who also need the most supervision from parents who may be essential workers and needing to not be at home doing really intense supervision of their kids' learning. So all of that lined up to be a safest approach to start with youngest learners. And as far as the recommendations that we gave for moving slowly with introductions, as far as doing this in stages, that was really modeled off things like the Safe Start Plan in Washington, where there is a progressive approach to advancing activities. You do an advancement of activities, you wait a certain period of time to make sure that you're not seeing any risk associated with that or any increased transmission associated with that, and then you proceed cautiously as long as things seem like they're going okay. And fortunately, so far, we have not seen any transmission between students at school. as far as I'm aware of, unless there's something that happened in the last 24 hours. So we have worked really hard with school nurses, with our principals or superintendents, with the staff, to make sure that they had all of their processes in place ahead of time, that they're supported when cases are identified, community-acquired cases are identified in students and staff, to really be cocooning around that case to make sure that there's no transmission. And we've been really successful so far. That's not to say that there won't ever be a time where we'll see cases spreading in schools, and certainly other schools across the state have experienced some outbreaks. But I think all of our hard work so far has been paying off in limiting that.
All right, thank you. And then we have another question. So where are outbreaks being seen in the county, and what does that mean for the next few months?
Yeah, so we know because of the nature of how COVID transmits that any congregate setting will always be a higher risk for transmission. And congregate setting just means a place where people necessarily need to gather, whether it's because that's where they live or it's where they work. So early on, we know that the biggest outbreaks we were seeing were in our long-term care facilities, where people who are vulnerable are living in close quarters with shared staff. We were also seeing outbreaks in some of our warehouses and meatpacking plants and other places where people tend to work closely together, and in homeless shelters, in the jail. So we've been really working hard with all of these groups over the past 8 months now. What month is it now? It's November. Over the past 8 months, to really try to optimize safety, to optimize all of their procedures and protocols, to make sure they have the PPE they need. We're pretty well versed in this now, and it's not to say that there can't be cases. There will still be cases, but we have certainly got better over this time at limiting that spread. So that was a really long way of saying that congregate settings, whether it's residential or workplace, is where we're going to see this. So we'll probably see more cases with employers with long-term care. Hopefully not in our shelters and our jail, but it's possible. Hopefully not in our school, but again, that's possible because it's a place where people congregate. And I just want to come back again to we will likely see more outbreaks as we have more cases spread in the community, and those community members go to their work or go to their shared residential space and introduce it there. So that will happen, but really we all have control over how much these outbreaks happen, over how much interactions we're having, or through how much interactions we're having in the community. So I know I mentioned before that we are allowed to have these interactions. I understand how important they feel, but every time we make a choice to not have one of those interactions, it makes the community safer, because it's less community transmission that can then get into these congregate settings and cause outbreaks.
All right, thank you. And then last thing, CDC recently updated the definition for a close contact. Could you talk a little bit about that as well?
Yeah, so I guess I'll just start by clarifying what the change was, and then maybe whether or not that should be important to you. So the change in the close contact definition, it still starts with that basic 6 feet, less than 6 feet for more than 15 minutes definition. The expanded definition always included things like what kind of space are you in? Is it a really small space? Is it well ventilated? How long was the time? Was it an hour? Was it 2 hours? So the definition was always a little bit longer than just that 6 by 15, but that's the basic starting definition, less than 6 feet for more than 15 minutes. And really what changed is they said that if you can add up a bunch of small pieces of time within 6 feet of someone to add to a total of more than 15 minutes in a day, that still counts as close contact. So it doesn't have to be 15 minutes in a row. It's 15 minutes of total contact time, less than 6 feet with that person. Again, there's other factors as far as the ventilation and the space and the duration of the exposure and all of those things, but that's the big change, is this total time versus all at once time, if that makes sense. And then as far as how should people maybe change their behavior, act differently, or what should they think about this? I hesitate to try to make people more anxious about COVID, because I think we're all tired of being worried and scared about COVID, but it does just mean that you need to be paying that much more attention to how close you are to people when you're out and about. Because if you spend 2 or 3 hours at the mall, it is feasible, or if you spend a long time in a store, which you're not supposed to, it's feasible that you could be standing next to the same person for more than 15 minutes, or within those 6 feet for more than 15 minutes, and not really have noticed, because it's 30 seconds here, 2 minutes there, 4 minutes there. So it just really underscores the importance of trying to maintain that social distance as much as possible.
Right. Thank you for that explanation. And so those are all the questions we have for today. So thank you so much, Melissa and Dr. Everson, for helping us answer those. If you have more questions that you would like us to address during our next broadcast, just leave them in the comments section. Thank you for watching.